Okay, here we go. Ready? We're going to talk about gastrointestinal and hepatobiliary pathophysiology. So much like our last lecture, okay, slide two, we're going to orient ourselves into basic anatomy of this thing. So we're going to work from the inside out. So the GI tract is not a simple tube. It's living, it's layered, it's an organ system, and each layer is performing a distinct function. So the question we need to answer is, how come the gut has four distinct layers rather than being this one flexible wall? So each layer from mucosa to serosa is forming this specialized division of labor. The mucosa is the innermost layer. It's where everything meets the world, nutrients, microbes, toxins. This is lined by epithelium that constantly renews and is supported by the lamina propria. And that's the home to many immune cells. And we'll talk about how that overlap happens from a previous immune-mediated response like we talked about from the pulmonary lecture. So there's another layer called the muscularis mucosa, and this is a thin muscle layer that helps move secretions and exposes more surface area for absorption. Underneath this submucosa, there's this communication hub. And this is the layer that carries blood vessels, lymphatics, and this rich nerve plexus called the Meissner's plexus. You don't need to know that unless you're on Jeopardy, but this is part of the enteric nervous system. So, where else have you seen this self-contained regulatory network before? Who else has an interplay of the mucous? Who else has this interplay of the mucosa and the internal autonomic functions? Well, this is similar to what happens in the pulmonary system. There's this pulmonary autonomic balance from the respiratory lecture that I want you to remember, where the parasympathetic constriction and the sympathetic dilation occurs as it affects perfusion. This also is the similar neuroregulatory system that tends to affect like the renal system. And we'll talk about those similarities as we go through because you're going to see a lot of the overlap. So the gut follows the same principle. There's a local control, but there's also this central oversight that happens. So pay attention to this muscularis externa. Now, this is where there is a circular and longitudinal muscle layer here you can see in the picture. This is where motility lives. This is where peristalsis and segmentation occurs, like a slow coordinated wave just pushing the nutrients forward through the GI tract. And the serosa is the outermost layer. This reduces friction as the loops of intestine slide against each other. Think of this like the visceral equivalent of synovial fluid in the joints. When you see me look over here, it's because I'm looking at your faces behind my screen. I have a third screen up. That's why I keep looking away at you. Anyway, beyond this wall itself, there are two major systems that plug into the architecture. There's this pancreatobiliary conduit, and this is the thing that delivers bile and digestive enzymes into the duodenal chemistry and chemical machinery here. There's another part of this which you need to pay attention to, which is the vascular and lymphatic network. Now, this is not only to absorb nutrients, but this serves as the first line of immune surveillance. A key theme we're going to revisit here is this inflammatory immune-mediated response, especially when we get to inflammatory bowel disease. So consider if the gut's primary function is digestion, why does it dedicate so much of its surface area to immune tissue? Well, the GI tract is the largest interface between the body and the outside world. Everything you eat, drink, and swallow is a potential antigenic challenge. So note the phase also in the GI tract of something called regional specialization. So for example, you'll realize that the mouth and the stomach don't do much for absorption, but rather it's the small intestine that handles the absorption. And the colon is where a lot of the water and electrolytes are reclaimed. So each region is built for its mission, just like you saw the nephron segments in our renal lecture, where you have like specialized areas for filtration, another area for reabsorption, and another area for concentration. This is the layered complexity that explains different diseases and target zones. So, for example, when we talk about ulcers, we'll talk about how NSAIDs erode the mucosa, whereas in Crohn's disease, you have this attack of a submucosa and the muscularis layer. So we'll also talk about things like when you deal with cirrhosis and how that affects vascular return in the portal system. The same structure that enables function will also start to define the different vulnerabilities that we'll talk about. So as we move forward, keep this layered anatomy in mind, because this is going to be the roadmap to understanding everything from ulcers to cirrhosis. So when you see inflammation or bleeding, your job is going to be to ask which layer has failed and why. So when a patient walks into you and says, I have stomach issues, your instinct might be to say, okay, acid reflux and move on, right? But I want to caution you against that impulse. The gut, like the mind, is going to speak to you in patterns, and your job is to decode it systematically. I don't want you memorizing, I want you noticing patterns. So the framing question that needs to occur to you is, what do all GI complaints have in common? Well, the commonality is they tend to cluster. The body is not giving us isolated symptoms, it's speaking in constellations. So we start by grouping symptoms into five major clusters. So the first cluster of symptoms you're going to pay attention to, often this is the thing that brings people to care, is pain. Often it's vague and it's referred and it can be colicky. The next symptom of clustered symptoms you're going to pay attention to are issues related to dyspepsia. So that would be like the burning and the postprandial discomfort. Or they may complain of altered bowel habits, diarrhea, constipation, or some alteration thereof. The major red flag for all of us is, of course, bleeding, and it could be overt or occult. And then jaundice, which is the unmistakable quote unquote yellow flag that the hepatobiliary system is involved. So each cluster becomes its own diagnostic pathway. And just as in renal pathophysiology, the pattern recognition is what's going to drive the probability. So let's pay attention now to pain. So there's a visceral versus parietal pain. So you have to ask yourself, why does this ulcer feel dull while peritonitis feels sharp? Well, visceral pain arises from organ distension or contraction. That's diffuse, midline, and poorly localized, whereas parietal pain comes when inflammation touches the somatic peritoneum. So they're sharp, localized, and it worsens with movement. So if you tie this to, say, something like pleural pain that we discussed in the pleural pulmonary lecture, both result from irritation to that somatic layer, which is designed to detect injury and not stretch. And time course matters here because we always want to know, is this acute versus chronic? And this separates the emergencies from the slow burns. So acute will suggest things like perforation, obstruction, ischemia, or infection. So pay attention to that. And then chronic points towards inflammatory or functional disorders, things like, Crohn's disease or ulcerative colitis or irritable bowel syndrome. So you always want to ask this question, if this were the heart instead of the gut, would you treat the chest pain without first ruling out an MI? So the same logic needs to apply here. You need to earn the right to call something functional. The next thing that's important to pay attention to is the history, because this is going to be the map to help guide you along. In addition to medications, especially things like NSAIDs, these are considered silent saboteurs because these will erode the mucosal defenses, leading to peptic ulcer and bleeding. Another thing to pay attention to in the history taking is travel. Have you traveled somewhere? Because now we're thinking about things like parasites and amoebiasis. Or have you ever had a history of surgery? Because now we're dealing with things like adhesions that can cause obstructions. Has your diet changed? Are you exposed to something? Because now we're looking at things like infection and dysbiosis. Or after antibiotics, say, have you recently been on an antibiotic and you've disrupted the biome? All of these different things can mimic inflammatory bowel disease, and each clue will narrow the field before you even touch the patient. So when it's time to order tests, what you want to do is you want to pair them to the symptom cluster. So for example, you'll pair the CBC looking for anemia or infection, or the comprehensive metabolic profile, the CMP looking for liver or electrolyte disorders, or stool studies if you're looking for occult blood, ova, and parasites and pathogens and the like. There's also a fecal calprotectin study and a lactoferrin study when you're suspecting things like inflammation. Well, all of these mirror similar frameworks where we use labs to reveal function and inflammation before you get to the structural problems. So you don't get to label something as a functional disorder And when I say functional disorder, that's what I mean by the IBS, irritable bowel syndrome, and the likes, until you have excluded an organic cause. So IBS is a diagnosis of exclusion. It's not a shortcut for a normal colonoscopy. You have to ask yourself, how certain am I, or am I just rationalizing my uncertainty? So before you jump to that, you have to make sure you are systematic in your approach. So before we go any further into this alphabet soup of GI disorders, we're going to pay attention to what really matters. We have to pay attention to these red flags. So before you call anything and treat it, you need to know what can wait and what cannot. So when a patient says they have stomach pain, how do you know it's safe to wait and watch versus we need to hurry up and get to the C-suite? So the answer is going to lie in these red flags and this physiologic smoke alarm. So the first major group of red flag, red alarms are the bleeding signs. Anything that looks like acute blood loss. So hematemesis, melena, hematochezia, syncope. These are the hemodynamic emergency clusters of GI. If the patient's gut is bleeding, you have to remember that blood volume and oxygen carrying capacity are going to drop rapidly. This is a big deal. This is like syncope is a last ditch compensatory mechanism trying to preserve whatever hemodynamic function is left, right? It's going to make you horizontal to try and perfuse your brain. So when you get to that point, these are red flags. If you see these bleeding emergencies, it's two large bore IVs on the way to the endoscopy, upper and lower. So don't sit on major bleeding signs and symptoms. So pay attention. And also, melena will often mean upper, and hematochezia will mean lower GI bleeds in general. But if that upper GI bleed is bleeding like nobody's business, that upper is going to masquerade as a lower. So quite pay attention to where the bleeding is coming from. So melena, typically it's an upper bleed. Hematochezia, usually it's a lower bleed. And yes, 9 out of 10 times it's going to be a superficial hemorrhoid that's putting blood in the stool, but you can't just jump to that conclusion. You have to be sure because if you miss the obvious, it's not going to work out well for you. Now, you always want to think physiologically, not just anatomically first. The next symptom cluster you need to pay attention to are complaints of dysphagia, odynophagia, persistent vomiting, and severe weight loss. What's the most dangerous diagnosis you could miss here, do you think? Well, the most dangerous diagnosis you could miss here with these symptoms would be malignancy and obstruction. So when food won't pass or it hurts to swallow, that's not GERD. It's a structural problem until proven otherwise. The third cluster of symptoms, these are a little bit slower. These don't happen overnight. This third cluster of symptom is the iron deficiency anemia and nocturnal fever symptoms. So these are chronic disease indicators. The body is bleeding slowly or chronically inflamed. An iron deficiency from chronic micro bleeds might be the first whisper that you're getting of someone that might have colon cancer. Another thing to pay attention to is fever and nocturnal symptoms. If you have that, you have to think about what's mediating fever. Why do you have a fever? There's a pyrogenic factor. Well, what is a pyrogenic factor? A pyrogenic factor is a manifestation of the immune system is being active. Remember, pyrogens are meant to protect you. The goal is to make you an inhospitable host to whatever's trying to attack you. So it's trying to make you higher than 98.6, ideally higher than 100.5. But nonetheless, the immune system is active and the gut should be resting. So think inflammatory bowel disease. This is where pattern recognition from the immunology is going to return. So make a little grid for you of the Th1, Th2, and Th17 immune pathways and look at what those common firings are. So that's a little study tip for you there because we've discussed them also in the pulmonary pathology, but they're reappearing here in the gastrointestinal. So that's the Th1, Th2, and Th17. Because what we're seeing here is this is orchestrating this chronic mucosal injury with respect to the GI tract. Now, there's a fourth cluster of symptoms, age, and family history that you need to pay attention to here. You're over age 50 with new GI symptoms. You can't ever dismiss that as reflux. This is like high risk zone for malignancy, vascular disease, and motility disorders. So any family history, especially of a GI cancer or inflammatory bowel disease, this is automatically rewriting your pretest probability equation. This is like, I can't just ignore this, at least do a basic workup and get them into GI sooner than later and lead with their age, because that is like the tell, the red flag. Something big is going on here. And this, what you need to pay attention to is all of these red flag triggers you're seeing here should help expedite imaging and endoscopy studies. These are not optional if you have these red flags. So, not after the next shift. This is go to the hospital now stuff. This is it needs a scope in you sooner than later. This is wake up the GI consult overnight and bring him into your life. If there's a red flag, there's no such thing as reassurance without visualization. And we need GI to visualize. Okay, now we're going to change our focus from general GI reasoning and we're going to start focusing on the major disease pattern. The first major disease pattern in GI patho is peptic ulcer disease. It's the first because I put it first in the presentation. But anyway, and we're starting at the top and kind of working our way down. So, peptic ulcer disease, this is the classic story of imbalance, acid versus defense. So, what you're asking yourself here, consider this. Why doesn't your stomach just digest itself? Right? Because under normal circumstances, it's perfectly calibrated system. There's aggressive acid secretion that's being kept in check by an equally robust mucosal defense system. So the balance tips even by a few degrees, now you have pathology. So let's pay attention here to some of these defining some of these lesions. So an ulcer is more than just sore. By definition, an ulcer is greater than 5 millimeters deep. And that means it's reaching the submucosa. So this is why the ulcer bleeds. It's crossed into vascular territory. Smaller erosions will stop at the level of the mucosa, but the ulcer will cut deeper where the blood and lymph is flowing. So it's the same principle you saw in renal pathology. Once you violate that basement membrane, it's then you get protein and blood starts to flow. Now, there are two major culprits that cause our ulcers, H. pylori and NSAIDs. So think of these as like twin little saboteurs attacking the mucosal integrity. H. pylori is this master of survival because it burrows beneath the mucosal layer and it produces urease. And this neutralizes acid and releases toxins that will inflame and erode. So this is the thing that makes infection one of the more potent known risk factors for developing an ulcer. NSAIDs, meanwhile, these things will disable your peacekeepers. And what are your peacekeepers? These are your prostaglandins. Well, where else did inhibiting prostaglandins play a huge problem? Think back to our renal lecture. So when the COX enzyme is inhibited, you lose this prostaglandin-driven mucus, bicarbonate, and blood flow buffer system. So in the renal lecture, the same thing happened. That same prostaglandin that kept those afferent arterioles open, or the ones maintaining gastric perfusion, when you block them, you're starving both the kidney and the GI gut. So this is how NSAIDs can offend your kidneys and also offend your gastric lining. But not all ulcers come from H. pylori and NSAIDs. Other factors can compound and play a factor, like what? Age, smoking, COPD, CKD. All of these increase partly through impaired mucosal repair and hypoxia. So chronic illness will weaken the tissue's ability to regenerate, and this is a consistent theme you're going to notice in each pathophysiology lecture. If you've not noticed the line due to impaired perfusion of fill in the blank, that's the underlying theme in all of these different conditions. When you impair perfusion, you set the stage for chronic hypoxic injury. In the lungs, it's COPD, but here we can set the stage for ulcer formation. Even something like SSRIs can raise the risk because it alters platelet function and local serotonin signaling in the gut. Those of you coming to psychiatry may be surprised to find out that the largest producer of serotonin in the body is where? Is it the brain? No, it's the parietal cells in the gut. That's the largest producer of serotonin. So, These are subtle but concerning trends. So, idiopathic, though, peptic ulcer disease, this is a case where no H. pylori and no NSAIDs and no clear trigger have occurred, and they're increasing in frequency. So, why might that be? Well, depends on who you talk to, but some people will say it's because we have changes in our local microbiology and ecology. We have more comorbid illnesses, we have new genetic susceptibility. Um, I don't know. This could be the guts equivalent of something like idiopathic pulmonary fibrosis. Basically, an inflammatory process that may have outlasted the trigger and the inflammation's not shut off and it just kind of continues on. So ultimately, what you're getting at is every ulcer is a story of imbalance here. One side is aggressive forces of acid, pepsid, bile leading to ischemia, and the other side is a failure in the defense mechanism of the mucosa, the bicarbonate, the epithelial restitution, and blood flow. So your job is to figure out where on this core pathophysiologic axis, when aggression is outweighing protection, erosion is going to follow. There's a little equation we call an ulcer equation. That's acid plus inflammation minus prostaglandin equals an ulcer. So acid plus inflammation minus prostaglandin equals an ulcer. So when you hear epigastric pain, your first reflex should not be to give them a PPI. It should be to figure out which side of the scale has tipped and why. Is it excess acid, duodenal, or is it a defense failure, gastric? So this question is going to guide every diagnostic and therapeutic decision that follows, and we're going to talk about how to distinguish as we move through. Okay, so let's review the basic physiology of gastric acid production here. So what you have are these mechanisms intended to protect the stomach from its own secretions. So gastric acid occurs in two patterns. There's basal secretion, which is mediated by the circadian rhythm and higher output at night. There's also stimulated secretion, which is triggered during cephalic and gastric and intestinal phases of digestion, meaning when you see the steak on the grill, immediately this starts. There's a cephalic phase that's mediated by the vagal stimulation in response to food anticipation. So, oh, we're going to eat, which means you're going to start getting hungry. Then there's the gastric phase that occurs, and this is when peptides and distension stimulate the gastrin release. Your belly gets a little bigger, making room to put food in it. And then there's the intestinal phase, and this provides the feedback control to slow the acid secretion as the chyme enters the duodenum. The chyme is the food after it passes through the stomach. So when you swallow, it's a bolus. When it gets through the stomach, it's called chyme. Okay. Now, in this gastric phase, the peptides lead to distension, and then the chyme enters the duodenum, and then you go to the parietal cell regulation phase. And there are three major mechanisms to pay attention to in the parietal cell regulation phase. And the first one you need to note is H2. Histamine 2. This activates the alendronate and cyclase to increase cyclic AMP because what we're doing is we're preparing for digestion. So this is giving you the energy to physically digest the food. The next hormone involved is gastrin, and this increases intracellular calcium, as does acetylcholine, which also increases intragastric calcium through vagal stimulation. And so this is all playing into what we call the proton pump. So when you say we're giving a proton pump inhibitor, what exactly are you inhibiting? Well, you're inhibiting this hydrogen potassium ATPase proton pump. And what you're inhibiting is the ability to secrete hydrogen ions into the lumen of the stomach. That's what the PPI, that's what the proton pump is. Well, there's another hormone called somatostatin, and this thing provides you the negative feedback by inhibiting gastrin and histamine release. So when somatostatin is suppressed, like an H. pylori infection, acid secretion increases unchecked. Now, this is one layer of it. Well, that's the acid part of it. Now you have the defense part. The defense part of this mechanism is also in three layers. You have the pre-epithelial layer. There is mucus and bicarbonate from a neutral or microenvironment that buffers acid at the mucosal surface. There's also the epithelial layer, And these cells are joined by a tight junction that prevents acid back diffusion. So as this progresses, you're going to also then see this response. And the purpose of this epithelial layer is to regenerate because epithelial cells are constantly sloughing off. So there's a subepithelial layer, which this requires adequate blood perfusion in order to remove the acid and diffuse inward to supply oxygen to that layer, because without oxygen, we get that hypoxic injury. And so that's what we're trying to contend with. So you can see how many backup systems are here and how vital this is, because without this system, you're dead. You need this to bring in the nutrients. So any state of hypoperfusion like shock, NSAIDs, prostaglandin inhibition compromises this defense layer. Now, there is this final thing we need to talk about when we're talking about gastric secretion, which is the prostaglandin role. So these are essential for maintaining the mucosal defense system. They stimulate mucus and bicarbonate secretion and promote mucosal blood flow. They enhance epithelial restitution after injury. NSAID-induced injury occurs because these drugs inhibit COX-1 and COX-2, which reduces prostaglandin synthesis. This is the same mechanism that explains NSAIDs-related renal hyperperfusion, and both the kidney and the stomach rely on prostaglandin-mediated vasodilation for protection. Now, peptic ulcer disease, the take-home message you need to get from all of this is that peptic ulcer disease results from an imbalance between two things: acid secretion and mucosal defense. Effective management requires identifying which side of the balance has failed. Is it excessive production or impaired mucosal defense? Let's see who needs to be let in. People coming late. All right, so let's take a look now at how acid is made and how it becomes destructive when H. pylori is the problem. So there's a virulence factor here. So H. pylori is uniquely adapted to survive in the stomach's acidic environment. There's a key virulence mechanism that it has called urease, and this converts urea to ammonia and carbon dioxide, buffering acid in its immediate surroundings and allows survival near the gastric epithelium. So what it's doing is it's creating an environment where it can replicate. So what happens is cytotoxin-associated gene A, known as CAG-A, that gets injected into the host epithelial cell via a type 4 secretion system. Remember that from the first lecture. This disrupts the cell polarity and promotes inflammation. There's also another cytotoxin called vacuolating cytotoxin A, and this alters immune signaling and increases epithelial permeability. And there's a third component to H. pylori, which is the adhesins. This promotes a firm attachment to the gastric mucosa, resisting the mechanical clearance process. So these virulence factors explain why eradication therapy has to target multiple bacterial processes simultaneously. In addition, this is why acid suppression alone is not sufficient. So look up the treatment protocol for H. pylori. Sometimes it's triple antibiotic therapy with a proton pump inhibitor. Now, what happens when the infection happens? Well, a good host is going to trigger the inflammatory response. So this triggers the chronic activation of gastritis, which is mediated by pro-inflammatory cytokines. Now take a look at these cytokines and tell me where you've seen those before. IL-11B, IL-6, IL-8, tumor necrosing factor, IL-8 specifically recruits what? Same thing it did in the lungs, but IL-8 specifically recruits neutrophils, which releases reactive oxygen species and protease that injures the epithelial cell. Where have we seen that phrase before? IL-8 recruits neutrophils, which releases reactive oxygen species and protease that injures the epithelial cells, wherever those epithelial cells happen to be. Pay attention to that line, wherever those epithelial cells happen to be. So think to yourself, where else might there be epithelial cells? This inflammation is neutrophil dominant now. So this leads to ongoing mucosal damage, even in the absence of a deep ulceration. This parallels the Th1 dominant response that we talked about in the pulmonary lecture, which is protective in intent but destructive in effect. Now, there are some regional effects on acid secretion. The pattern of infection determines whether acid secretion increases or decreases. So if you have antral predominant infection, that's the front of the stomach, reduced somatostatin, you're going to have increased gastrin and acid production. This predisposes you to a duodenal ulcer. You may have corpus predominant infection, that's glandular atrophy and parietal cell loss, leading to decreased acid production, and that can predispose you to gastric ulcers and atrophic gastritis. So H. pylori is not simply an acid promoting organism. It dysregulates acid control differently depending on the location. And I'm going to give you a chart that shows this, but you have the slide, so you're probably skipping ahead. So let's talk about this. This is the NSAID-induced version of how do we get an ulcer. Unlike the H. pylori inflammation-driven, this one is kind of iatrogenic and dose-dependent, and it can be both systemic and just local. So the first prostaglandin we need to look at here is COX inhibition and prostaglandin depletion. So NSAIDs inhibit COX-1 and 2, which are required for prostaglandin synthesis. Now, when you have a loss of prostaglandins, this leads to reduced mucus and bicarbonate secretion. This reduces the surface protection of the lining. And then that leads to reduced mucosal blood flow. And what happens when you reduce the blood flow to somewhere? Well, you get ischemic vulnerability. And then, if you have ischemic vulnerability, how does that vulnerability manifest? Well, there's reduced epithelial restitution and repair. So COX-1 is a constitution of this protective, and COX-2 is this inducible, primarily involved in inflammation. But when you non-selectively block both, while COX-2, things like celecoxib, Celebrex, those are selective agents, they will spare some mucosal defense, but they still carry cardiovascular risks. So this same prostaglandin loss will explain why things like NSAIDs can precipitate acute kidney injury, particularly in a hypovolemic or elderly patient. Both the kidney and the stomach are very dependent on prostaglandin-mediated vasodilation. Now, something else to pay attention to is this topical epithelial injury. So NSAIDs are weak acids. So when they diffuse into epithelial cells in their non-ionized form, they become trapped in the acidic intracellular environment and cause direct cellular injury. At the same time, though, these increase epithelial permeability, which allows more hydrogen ions and biosalts to penetrate, and this is the most pronounced lipid-soluble NSAID, and that is things like ibuprofen or naproxen. Less so with enteric-coated formulations because why? It just dilutes further along in the GI tract. Also, less offensive, but not completely inoffensive with parenteral formulation. So your injectable Toradol is a little bit safer, but in general, theoretically, it's inhibiting prostaglandins and you can have this, but later on. So there's another thing to pay attention to here, which is this inflammatory amplification. NSAID's injury is worsened by secondary inflammation. So neutrophil adherence to vascular endothelium, the release of tumor necrosing factors and various leukotrienes, all of this just amplifies the mucosal ischemia and oxidative stress. So what you're getting here is this perpetuation of ulcer formation even after the initial chemical insult. And it works synergistically. So when H. pylori infection and NSAIDs coexist, the risk of ulceration is like multiplicative, not just additive. So this is like, I have stomach pain, it hurts. What did you take? I took NSAIDs for my stomach pain. See the problem? You've already insulted the bowel twice. So the infection compromises the mucosal defense, while the NSAID will simultaneously reduce the prostaglandin. And then you have two distinct pathways that are converging in the same endpoint. And so this is why this can be quite problematic. Uh, So you should know NSAID-related ulcers are preventable. For at-risk patients, you're supposed to use the lowest, most effective, shortest duration of dose. You do want to prescribe things like PPIs or misoprostol because why? What's misoprostol, also known as Cytotec? Misoprostol is a prostaglandin in here, is a prostaglandin essentially, right? We give that to dilate the cervix to trigger childbirth and ripen it. It's the same prostaglandin you can give. It's non-specific. It goes wherever prostaglandin is needed. Also, don't ever forget if someone's complaining of symptoms, you should always screen for H. pylori before putting someone on long-term NSAID use. Now, think about that. Who normally is doing long-term NSAID use? Ortho. How many orthopedics do you think are screening for H. pylori? None. So, this is where your role as primary care comes in. You're going to inherit this patient, and it would not be a bad thing to screen them for H. pylori to make sure we're not setting this catastrophe in motion. Okay, let's take a look now at something very practical. These are how your patients may present to you. We're going to look at some characteristic pain patterns. Now, the hallmark symptom is epigastric pain, burning, gnawing, aching quality. The duodenal ulcer pain typically improves with food. Let's say that again, because you might see that somewhere. A 32-year-old man walks into your clinic who reports epigastric pain that improves with food, but returns 2 to 3 hours later as acid secretion rebounds. Whereas gastric ulcer pain worsens with eating because food is stimulating acid release directly into an already inflamed stomach. So, this simple distinction of pain relieved versus aggravated by food will help localize the pathology, though this is not an absolute. But it's helpful in the clinical setting. It's low tech, high yield. Always interpret this in the context of history and risk factors, NSAID use, H. pylori, age, smoking, chronic illness. Another thing to pay attention to here is asymptomatic or silent ulcers. So up to half of ulcers are asymptomatic, especially in older adults or those using NSAIDs. Now, for many patients, the first clinical manifestation is a complication, typically bleeding or perforation. So this is why unexplained iron deficiency anemia or melena should trigger your search for an occult GI source, even in the absence of pain. Now, there are some major complications that can happen here, the least of which is gastrointestinal bleeding, which is the most common and unfortunately often the first clue. Many patients will present with hematemesis, that's upper GI bleed, or melena of partially digested food. Massive bleeding can cause both hematochezia and hemodynamic instability. So bleeding is bad, and it's bad when this is your first sign of trouble. Another major complication is perforation. Now, this results from full thickness erosion of the gastric and duodenal wall. This was shown in Downton Abbey when he vomits blood at the table. He perforates his ulcer. Even in the early 1900s, the treatment back then was the gastrectomy to remove everything below. At any rate, perforation is a very big deal, and it's done through eroding all the way through. And patients will develop severe, sudden epigastric pain with rigid abdomen, and they'll have free air under the diaphragm on imaging. This is a true, true surgical emergency. And then also sometimes you might notice they'll present with a gastric outlet obstruction. Well, this happens when scarring or edema near the pylorus narrows the lumen. So what happens is patients will report to you, I just can't eat as much. I just feel so much easier. This is not the one on the GLP-1. You got to take that out of the equation too now. Remove the GLP-1 from the equation, and if they're still reporting early satiety, vomiting of undigested food, or a succession splash on physical exam, that may help cue you into um, some sort of outlet obstruction. Now, there are some alarming features to pay attention to. These require prompt evaluation and immediate endoscope. Anything related to bleeding. Iron deficiency, you can scope them, but maybe not overnight. You can wait till tomorrow to scope them because this is not a new problem. Unintentional weight loss, persistent vomiting could be a possible obstruction. These findings could suggest major complications, malignancy, or both. So these are the ones you want to make sure you're advocating and moving through the system. Urgent evaluation for things like severe or worsening pain, new onset dyspepsia in a patient over 55 years old, Any family history of gastric cancer. This approach prevents the delay in diagnosis of malignant ulcers, which can initially mimic benign disease, so you need to pay attention. There is an increased risk of developing a lymphoma with ulcerative disease, so you have to make sure we're not missing that. Most peptic ulcers are going to heal with appropriate medical therapy, but morbidity and mortality rise from delayed recognition and the complications. So the safest clinical mindset, any unexpected anemia, melena, change in symptom pattern, what do? Endoscopy referral. Early identification and eradication of H. pylori can also be done, and then tailor the NSAIDs as well. All right. So take a look here now. This is our decision tree. So pain, quality, timing, these can't distinguish the ulcer from a functional dyspepsia or malignancy. So we need objective testing like upper endoscopy and H. pylori detection. So indications for endoscopy, this is the gold standard for diagnosing peptic ulcer disease and identifying any complications or malignancy. You perform an endoscopy in any of the following circumstances: age greater than 55 with a new or changing symptom, risks of malignancy that are increased significantly after this age. Presence of alarm symptoms, GI bleeding, iron deficiency, unintentional weight loss, persistent vomiting, or dysphagia. If there is a suspected gastric ulcer, always biopsy to rule out gastric cancer. And symptoms refractory to empiric therapy that are persisting dyspepsia, say after 4 to 8 weeks of PPI, you need to scope that person. Duodenal ulcers are rarely malignant, but gastric ulcers always need to be biopsied. H. pylori testing can be done in a whole host of ways, endoscopy not the least of them, but that's invasive. You can do breath urea test, you can do a stool antigen, many ways to test for H. pylori. PPI therapy, antibiotics, and bismuth should be discontinued for at least 2 weeks before testing for cure because you can get a false negative. So you need to complete the therapy and give a 2 week break before you test for cure. Now, beyond direct testing, looking for underlying risk factors like NSAIDs and aspirin use, smoking status, family history, a previous history of H. pylori treatment, because they can develop reinfection later on. All of these contextual assessments are going to help distinguish NSAID-induced from infection-related ulcers, and this is going to help you figure out what do I need to do with this person. So here is a table for you to help distinguish the difference between the types of ulcers. While both of these umbrellas are falling under what we call peptic ulcer disease, they differ by location, pathophysiology, and clinical behavior. So take a look here at the location of gastric ulcers. These occur within the stomach, most commonly along the lesser curvature of the antrum. The lesions form where acid exposure and mucosal defense intersect. The duodenal ulcer occurs most exclusively at the first portion, the bulb of the duodenum. This is the segment that receives both gastric acid and bile. The anatomical difference reflects those differing vulnerabilities. So gastric ulcers are largely a defense failure, whereas duodenal ulcers result from acid excess. Another thing to note here is the acid production pattern. So in gastric ulcers, acid secretion is typically normal or decreased. The primary defect is impaired mucosal defense, often from H. pylori, or atrophic gastritis, or NSAID injury. Whereas in duodenal ulcers, acid output is increased in about 60 to 80% of cases. So the risk is linked to the antral predominant H. pylori infection, which suppresses the somatostatin, leading to increased gastrin release and enhanced parietal cell activity. So this is the distinction why you get anti-secretory therapy is universally helpful, but prevention strategies differ. So you're going to either restore the mucosal defense for a gastric ulcer, or you're going to control acid release for the duodenal ulcer. The other thing to pay attention to is the pain pattern in trying to distinguish these two. Gastric ulcer pain typically worsens with eating. Duodenal is typically relieved with eating and then returns a few hours later. The other thing that's common with duodenal ulcer is nocturnal pain. This is common because acid secretion peaks during fasting states. So, not diagnostic, these timing patterns can help prioritize. So, let me throw a wrench into your works here. Now that people are on GLP-1 inhibitors, it's going to be harder to have this pain pattern because gastric emptying is decreased and they may not have the same secretion, which means this ulcer can go longer flying under the radar. So, it's just something to pay attention to raise your index of suspicion because of the delayed gastric emptying associated with those medications. Other thing to pay attention to is malignancy risk. So gastric ulcers have a 1 to 4% malignancy risk, and they always have to be biopsied to rule out that adenocarcinoma or lymphoma. And duodenal ulcers almost never have malignant biopsy results, so that's typically reserved for non-healing lesions down the road. Okay, finally, the H. pylori pattern. In gastric ulcers, infection is usually corpus or antral predominant, sometimes with atrophic gastritis and reduced acid production. Duodenal ulcers, the infection there is antral predominant with increased gastrin and hyperchloremia. So this is driving the mucosal injury. The difference is in the infection site, explains why H. pylori eradication lowers both the ulcer recurrence and the gastric cancer risk. So treating an ulcer is cancer prevention, but through slightly different mechanisms. Okay, so let's summarize this up. Gastric ulcer means mucosal defense failure, possibly malignancy. Biopsy is required. Got that? Gastric ulcer means mucosal defense failure, possible malignancy, biopsy required. Duodenal ulcer means acid excess, usually a benign course. Acid suppression is effective. So getting those distinctions is going to help you refine the diagnosis and deal with the surveillance and treatment planning. Okay, what time is it? Why don't we take a 5 minute break since the eyes are glassing over? And what we'll do is come back to inflammatory bowel disease after the break. So set your clock for 5 minutes. All right, guys. I realized that that last portion didn't get recorded. So we'll see what we can do to fix that for you. But suffice it to say, let's start with the cirrhosis and pathogenesis of fibrosis. So chronic injury triggers stellate activation. Okay. And every form of chronic liver disease, be it viral, toxic, metabolic, autoimmune, shares this common final pathway of persistent hepatocellular injury. And when injury becomes repetitive, the liver's normal wound healing machinery gets stuck in the on position. And these injured hepatocytes and inflammatory cells release these cytokines of TG beta, IL-1 beta, and PDGF. And these signals awaken the hepatic stellate cells. Normally, they're quiescent in vitamin A storing cells in this disease. So once activated, this transforms into a myofibroblast-like cell, and that produces an extracellular matrix. That's the ECM you see on your screen there. And what happens is this collagen, laminin, fibronectin, this initially is a protective response. But over time, what happens is this becomes pathologic, and scar tissue replaces the parenchyma, and that distorts the liver's vasculature and lobular architecture. So fibrosis is not just passive scarring, it's like active biological remodeling gone rogue. And that's the process of how cirrhosis begins. So what you have is this architectural distortion and regenerative nodules. And the next phase is architectural chaos. So as the normal hepatocytes attempt to regenerate with fibrotic septa, they form these nodules. And these clusters are functional cells surrounded by non-functional scar tissue. Well, these regenerative nodules give the cirrhotic liver a nodular surface, and what you palpate as firm, irregular, and shrunken, but beneath that surface is this critical issue that isn't just scarring, it's the rerouting of the blood flow. So the sinusoids lose their fenestrations and the capillarization occurs, which is more capillaries are forming, and this portal venous blood begins to bypass the hepatocytes altogether. Well, what happens is there's a decreased detoxification ability and synthetic dysfunction, ultimately leading to portal hypertension. Also, in cirrhosis, the decreased hepatocellular mass and altered blood flow leads to hepatocellular shrinking. And then there's fewer functioning hepatocytes, which means there's reduced metabolic capacity. And so that's when your albumin starts to fall and your INR starts to rise. Meanwhile, there's this increased resistance to portal flow, which leads to this sinusoidal hypertension, and the blood is unable to traverse that stiffened hepatic parenchyma, and it diverts to the collateral channels. Where are those collateral channels but the esophagus, the stomach, and the rectum, creating varices. So cirrhosis is both a cellular disease, loss of hepatocytes, but it's also a hemodynamic disease altered by intrahepatic flow. And this dual insult will explain why two cirrhotic patients may have the same biopsy stage but entirely different clinical courses. One is compensated, the other is decompensated. So, what this is doing is I'm setting the foundation for you to get to portal hypertension and systemic complications. Everything that follows, ascites, splenomegaly, varices, hepatoencephalopathy, all stems from this distorted architecture. Fibrosis compresses the sinusoids and the central veins, leading to portal pressure increases, promoting the splenic vasodilation. And as the venous return redistributes, renal perfusion drops. And that sets the stage for the hepatorenal syndrome. Meanwhile, that hepatocellular dysfunction reduces the detoxification ability, leading to ammonia accumulation and eventually encephalopathy. So each complication downstream is an echo of that same structural injury. So when you see a patient with cirrhotic liver or ultrasound or CAT scan, you need to remember that each fibrotic band represents a failed repair attempt, a scar left by a survival process. And that process is gradual. It's reversible early on, but then once it goes under full fire, it becomes this self-perpetuating mechanism. So your intervention with antivirals and alcohol abstinence and metabolic control are all aiming to interrupt that stellate cell activation loop before the architecture collapses. Now, fibrosis's biology comprises between healing and harm. It's the liver trying to save itself, and in so doing, it seals its own fate. So, understanding this duality is foundational for treating not just cirrhosis, but the disease that's feeding this process. So now that you've seen how fibrosis develops, this is the slide that asks the next critical question. When does cirrhosis become clinically significant? Well, the distinction between compensated and decompensated cirrhosis is more than academic. This is the line between silent disease and systemic failure. Compensated cirrhosis, this is the silent plateau. In compensated cirrhosis, the liver sustains damage, but it maintains enough functional mass to meet the body's metabolic demands. The patient can remain asymptomatic for years, even decades, before remaining hepatocytes give up the ghost and hyperfunction is offset to loss. So the key concept here is to reverse. Synthetic function is preserved. Albumin and INR could still be normal here. There is still hope. The portal pressure is rising, but it hasn't yet disrupted the systemic hemodynamics. The architecture here is distorted, but the physiology is holding on for dear life. So this is the window for detection and intervention. This is the window for the reversible phase. This is where lifestyle changes, antiviral therapy, alcohol cessation, and metabolic control can still halt and regress the fibrotic state. So in compensated cirrhosis, it's not stable, it's just temporarily balanced. And the clock is ticking. So even if the labs look calm, they're going to go off soon. Contrast that with decompensated cirrhosis. This is the collapse of compensation. So this marks the moment when the hepatic reserves are starting to fail, when the architecture and hemodynamics are overwhelmed. This is defined by appearance of one or more of major complications. So decompensation has happened when you see things like ascites, variceal bleeding, hepatic encephalopathy. These are not just the symptoms. This is the threshold event that has now transformed the prognosis. So once decompensation occurs, median survival rate drops below 2 years without a transplant. So if you have this physiologic tipping point here where the hepatic venous pressure gradient is greater than 10, this quantifies what we're going to call portal hypertension. This is clinically significant portal hypertension when that pressure exceeds 10 millimeters of mercury. This is the point where complications become likely. If the hepatoveno pressure gradient in the liver is above 10, it can still accommodate the blood flow, but we're starting to enter variceal territory when we hit 12, and that risk starts to increase exponentially. There's another prognostic cliff, and this is the sobering reality that when the transition goes from compensated to decompensated, basically that 10-year survival rate is, in compensated, it's 10 years or more. But when you hit that decompensated state, you've hit the 2 years or less mark. And there's no going back once you have ascites and varices. At this point, you're just managing decline. So every episode of decompensation, a variceal bleed, infection triggered by encephalopathy, recurrent ascites, that puts you on the transplant evaluation list. That's when they start calculating things like your MELD score. And at the bedside, the question is, it's not, does the patient have cirrhosis? It's really, what stage are we in? Are you compensated, monitor, treat, etc.? Or are you decompensated and we're managing complications? And that entire management strategy pivots on, are they compensated or not? This is the slide here on portal hypertension. I made a separate 4-minute video on this. You can watch this separately on your own time. I won't cover it here because we're getting near the end, but I will put that there. It's already posted. You can download the notes from that. The subtitles, for some reason, are having some difficulties. Okay, so let's talk about ascites now. So portal hypertension, this is the engine where smoke is escaping and the system can no longer contain its own pressure. This is the slide that shows you the process of ascites. So how do we get to ascites? So what we have is splenic artery vasodilation, that is arterial underfilling. And this story begins due to excessive nitric oxide and vasoactive mediators. Nitric oxide dilates, and that diverts a massive portion of effective blood volume into the visceral vasculature. The problem is, it's a paradox. So even as total body volume rises, arterial underfilling is occurring because the kidneys are now sensing this hypovolemic state. So even though the patient is often fluid overloaded, this is setting off a misguided rescue mission and it's triggering that RAS system and that sympathetic nervous system activation. And what happens is sodium and water is being retained. And there's a perceived underfilling that activates that RAS system. Aldosterone is driving up the sodium absorption at the distal nephron, and antidiuretic hormone is promoting free water retention. And so the body is responding to this high pressure, adding more volume in a closed circuit. So what's happening is you're getting this neurohormonal overreaction. The kidney's trying to fix it, but really it's making it worse because it's basically rerouting the rivers into the liver. And the liver's like, I can't handle all this because it's all going to the liver. It's not going to the kidney. The kidney's saying, we're not being perfused. I'm going to trigger my emergency response system. So that's the hepatorenal syndrome. Meanwhile, that elevated portal venous pressure is increasing capillary hydrostatic pressure in the splenic bed, and lymphatic drainage is starting to surge up to 20 times normal in advanced cirrhosis. And so what's happening is that lymphatic fluid has nowhere to go. It's not producing albumin, so it can't hold it into the vasculature. And so the result is this slow leak of transudate and straw-colored protein fluid. And that's how the fluid starts to shift and you get peripheral edema, and then there's nowhere to go, so it leaks through the capillary bed and you have ascites. And so that's why lower extremity edema and ascites will often coexist. It's not a random distribution, it just follows gravity. And so that's what's happening because the protein is not able to maintain that oncotic pressure that we talked about in week 1. And so the body is essentially failing. And so that's why ascites is one of these precedes of other decompensation events. So, at the bedside, every management step is going to target sodium restriction to limit the substrate retention. You may do spironolactone and Lasix to counteract the aldosterone-driven reabsorption. You might do a paracentesis with albumin infusions to correct that oncotic deficit and decompress the portal circuit. You may do a TIPS procedure with a transjugular intrahepatic portosystemic shunt. And the whole purpose of that TIPS procedure is to simply relieve the pressure, but what happens is you wind up risking major encephalopathy, but that's the trade-off. So each intervention is meant to interrupt the loop of vasodilation, underfilling, RAS activation, and retention ascites. Ascites is never an isolated event. It's just the visible expression of invisible hemodynamic warfare. So the body is in an attempt to preserve perfusion. So that's what you're seeing. So by now you've traced this path from fibrosis to portal hypertension and fluid overload leading to ascites. Well, now we have to talk about varices and bleeding because this is the collateral formation of what's happening as a result of the detour. When intrahepatic resistance becomes so insurmountable that blood is looking for any escape route, the body is responding by creating a portosystemic collateral circulation network. And so what's happening is it's detouring blood from around the high pressure liver circuit. And so what happens is the esophageal and gastric varices, left gastric vein, will become engorged. That's basically a varicose vein, whether it's a hemorrhoid or a varice or around the stomach. Rectal varices via the superior rectal vein and the caput meduase, which is the periumbilical vein. So you might see that spider angiomas as a sign of liver failure. That's all you're seeing is essentially this high pressure system is looking for an out. So it tries to create little rivers. And these are structural evidence of systemic hypertension, and each collateral is a mark of a high pressure system in a thin walled vessel. And unfortunately, it's only going to be a matter of time before it ruptures. The risk of rupture depends primarily on two factors: portal pressure, that's the driving force, and the variceal wall tension. That is, how thick is that wall? How much pressure can it withstand? And the relationship essentially follows the wall tension equals pressure times the radius of the vessel. There's just a formula to it, but suffice it to say it's going to burst. And if you've ever seen someone vomit up due to their esophageal varices, that's what's happened essentially. The dam has broken. The way we treat this is with non-selective beta blockers. These can be life-saving even before bleeding occurs because we're just trying to lower the pressure in the system. You can also develop a condition called portal hypertensive gastropathy. This is the hidden contributor. Not all bleeding comes from the varices. Portal hypertensive gastropathy is a diffuse mucosal vascular dilation in the stomach, and that causes an elevated pressure, and it can lead to slow or chronic bleeding, iron deficiency, rather than like a sudden hemorrhage. So it becomes a slow leak. And what happens is you get a clinical presentation from a warning leak to a catastrophe. So when the varice ruptures, the presentation is unmistakable. I mean, you'll see melena and hematemesis, and sometimes at the same time. That's a medical emergency, and it's a messy medical emergency if you've not been in the ER or the SICU when that's being handled. But there is a window of prevention, and that's why we try to screen with endoscopy and ligate those varices, start them on the beta blocker, and try to reverse whatever is modifiable. Hepatic encephalopathy. So if portal hypertension is the body's plumbing problem, hepatic encephalopathy, this is like electrical failure in the body due to the liver damage. This is the brain's progressive loss of metabolic insulation as the liver ceases to filter its own waste. And what's happening here is this portosystemic shunting and decreased hepatocyte mass leads to neurotoxins that can bypass the blood-brain barrier. And what am I talking about there? Well, essentially, the liver is supposed to detox the ammonia out of the system, but it's failing at doing that. And so ammonia is now essentially entering the brain, causing this encephalopathic condition. And blood is bypassing the liver via all these collateral vessels. And so this toxin is essentially just building up and crossing the blood-brain barrier, altering the brain's ability to regulate, and causes this alteration in mental status. Ammonia is the primary neurotoxin. It remains central. It's produced by the gut through bacterial breakdown of proteins and urea. And normally it's converted by the hepatocytes into urea and glutamine, and then you can excrete those out of the body. Well, when this fails, ammonia crosses into the central nervous system and the astrocytes absorb it, forming glutamine in the brain. And what happens is these astrocytes will swell, lead to cerebral edema, and then there's altered neurotransmission. But what happens is the ammonia levels don't always correlate to symptom severity. So you can have a patient in a deep coma with a moderate ammonia level, or mildly confused patient with a sky high level, because ammonia is just one piece of the factor there. It's really how swollen are those astrocytes. Now, there are some other contributors. There's some false neurotransmitters and cytokines. So beyond ammonia, other toxins that can accumulate and disrupt the dopaminergic balance, which then leads to movement disorders. There's also some short-chain fatty acids that can interfere with the GABAergic signaling, and some inflammatory cytokines, which amplify the neuronal dysfunction through microglial activation. So hepatic encephalopathy is not just ammonia intoxication, it's neuroinflammation metabolic syndrome, essentially. The brain is overwhelmed, not just by what enters, but what can no longer be regulated. And common precipitants like the final push could be something like a sudden GI bleed, which increases the nitrogen load in the gut, and then it's more readily available. Infection, cytokine surge can trigger catabolism, electrolyte disturbance like hyponatremia or hypokalemia. Sedative and opioids and benzos can amplify the GABAergic tone, which is why we want to be careful in giving those in these agitated patients. Constipation obviously can increase the ammonia absorption. So there's a lot of precipitants, and we want to target where we can. So in this slide, I want to distinguish altered mental status in liver disease from hepatic encephalopathy, because it's not the same thing. So what you want to do before ruling in the hepatic encephalopathy is always rule out other causes of altered mental status, like sepsis infection as the most common mimic, drugs, opioids, benzos, antihistamines, electrolyte derangements, hypoglycemia, or some sort of intracranial pathology, say due to a fall or a head bleed. You never want to label a patient as hepatic encephalopathy until you've ruled out these other causes. So keep in mind, someone in liver failure could fall down and smack their head. But if you call them hepatic encephalopathy, that's a very end stage thing, and you may not be able to reverse, but you're missing this underlying reversible condition. So that's why don't just say hepatic encephalopathy equals, altered mental status. They're not one and the same. You need to distinguish them from each other. Hepatorenal syndrome. This is if hepatic encephalopathy represents the surrender. The hepatorenal syndrome marks the kidney's silent collapse in relation to this. It's a functional renal failure without structural damage. So the kidney in this case is collateral damage in about 10% of patients with advanced cirrhosis. The kidney fails not because they're diseased, but because they've been cut off from circulation. This is not intrinsic renal disease. This is the kidneys themselves are histologically normal, but they're shutting down because of the hemodynamic environment around them is not able to support them. So hepatorenal syndrome is the kidney's version of dying from neglect. The organ is intact, but signals reaching it are fatally misdirected. And the core mechanism here is that splenic vasodilation loop that drives ascites, which now underlies the renal failure. So in this sequence, splenic vasodilation from nitric oxide and the inflammatory mediators is triggering arterial underfilling, say in the renal artery. So that effective blood volume is decreased despite fluid volume overload. This RAS sympathetic nervous system activation is an attempt to restore perfusion. That leads to renal vasoconstriction. It can become severe, which reduces renal plasma flow and glomerular filtration. So even as the patient appears fluid volume overloaded with tense ascites, the kidneys are behaving as if they are in shock in a low flow state in a high volume body. And that's why the fluids rarely help in this situation because it's not even able to get to the kidney. Let's see what's in the chat here. Yep, sometimes they do need to go on to CVVHD. That's exactly right when these kidneys fail. And sometimes they go into liver ECMO as well to try and bypass liver circulation. So there are two trajectories here. There's the tempo trajectory, and this is where there's rapidly progressing renal failure. Creatinine doubles within 2 weeks, and this is often triggered by infection, bleeding, or large volume paracentesis without albumin replacement. The prognosis in that is poor, and median survival is often less than 2 weeks without transplant. And this is the acute collapse that the kidneys abruptly exit from circulation. There's a type 2 here in hepatorenal syndrome. This is the more stable kind. It's the chronic course, often accompanies refractory ascites responding partially to albumin and vasoconstrictors. Better prognosis, but still a marker of advanced disease. And these two forms only differ in speed, not in mechanism. So microscopically, the kidneys of a patient with hepatorenal syndrome look normal. There's no necrosis, no inflammation. The hallmark is that the reversible functional renal failure is because of the underlying hemodynamics, not that there's something structurally wrong with the kidney. Okay. So what we have now is this spontaneous bacterial peritonitis and hepatocellular carcinoma, two other conditions we're going to talk about now. Now, both of these are silent until they are catastrophic, and both are detectable if you are vigilant. So spontaneous bacterial peritonitis is a hidden infection. And this occurs when bacteria translocate across the intestinal wall into ascitic fluid. No perforation, no surgery, just failing immune barriers. So it's like a slow leak. And at a stagnant peritoneal pool that has become like the bacterial cultural medium. So the key mechanism here is this issue of portal hypertension leading to bowel wall edema, which as you increase the edema, you increase permeability, allows for bacterial migration, and then you can then infect and eventually slowly leak, perforate, and infect. This is an infection of opportunity, not exposure. Um, so when you do ascites tap, what you want to do to check for this is screen for this. You always want to do a cell count and a culture. And you also want to check albumin level because this cluster of testing will help confirm that the ascites is portal hypertensive in origin, and this small bacterial peritonitis can present without fever, so without pain, and sometimes only as encephalopathy. So if they're cirrhotic with ascites, um, you need to tap this person and then you need to do these tests, the cell count and the culture, to tell you if you are heading in this direction. Ascitic fluid studies, this is the diagnostic backbone, and so that includes cell count and differential to detect for this. The culture will tell you what the antibiotics are needed to treat it, and the albumin will help you distinguish is this portal hypertension or from malignancy. Okay. So where are we here? GI bleed, how do we manage this? When a patient presents with a GI bleed, your first task is going to be to localize it, and you want to follow this flow chart to try and triage. So the initial assessment is to establish stability before specificity. So begin with a hemodynamic assessment in any GI bleed. We don't care source until we can get them stabilized because they may not live long enough. So immediately you're going to look for hypotension, tachycardia, and orthostasis. If that's not stable, that's the two large bore IVs, and send the CBC and coagulation profile with the type and cross match. If they're unstable, then you resuscitate immediately with crystalloid and blood, O negative, as indicated. Never delay stabilization to finish labs or wait for GI. Tachycardia is often the first sign, and hypotension is the last, just to give you an idea of how serious we are. Then you want to stratify the source by looking for upper versus lower. Once they're stable enough for evaluation, then you can do upper GI and lower GI scoping, and then you can trend the BUN and creatinine. If you have a ratio of BUN to creatinine of greater than 30, that is suggestive of an upper source, upper GI bleeding source, due to the increased urea absorption from digested blood. The other thing you can do is nasogastric aspirate. That can confirm active upper GI bleed, although it's not always necessary. If the blood is coming out of the NG tube, you know how bad we are at that point. The upper GI bleed workup and timing is most common, and the most common cause is going to be a peptic ulcer disease or something like a Mallory-Weiss tear. That's a tear in the esophagus due to the retching due to vomiting. Those are usually self-limiting in nature. Or if they have erosive gastritis. EGD within 24 hours, and if varices are suspected, that's who gets started on octreotide and antibiotics, and also a proton pump inhibitor while they're going to go in there and hopefully essentially ligate. If they're having a lower GI bleed after the upper GI is excluded, then we're looking at causes like diverticulosis, angiodysplasia, ischemic colitis, and malignancy. So obviously the lower GI is going to need a whole bowel prep. So this is not a fast thing that we can do. So once they're stable, then you do the bowel prep. And then you can proceed. In the meantime, you can do CT angiography to localize before the intervention. And if both upper and lower scopes are negative, then you have to evaluate for small bowel sources. That's where capsule endoscopy is going to be useful. The red flag for urgent intervention is always going to be to treat the potential massive GI bleed requiring immediate escalation first, hypotension or tachycardia unresponsive to fluids, hemoglobin of dropping greater than 2 within 24 hours. Those are going to be your major red flags for scoping. Okay, so what's the algorithm if a patient presents with jaundice? Well, step one, you want to fractionate the bilirubin. So the first and most critical is to move to determine, is this unconjugated, that is indirect bilirubin that has not yet passed into hepatic circulation, or is it conjugated bilirubin that has already been processed by the hepatic sites? And that's into the bile. This is the division that determines whether the problem is before, within, or after the liver. Unconjugated means prehepatic or intrahepatic metabolic, and conjugated is intrahepatic or cholestatic. Step two is unconjugated, hyperbilirubinemia. If the bilirubin is predominantly unconjugated, then the hepatocytes are functioning, and this problem lies in either excessive production or defective conjugation. The key thing to note here is in isolated indirect hyperbilirubinemia, ALT, AST, and ALK phos are all normal. If the liver enzymes are normal, you're not dealing with liver disease, you're dealing with a bilirubin metabolism problem. Whereas in step three here, if it is conjugated, that means you're dealing with hepatocytes that have done their job, but the bile flow is disrupted, and now you know where you're located. It could be hepatocellular inflammation or a cholestatic obstruction. And then what you're going to do at step 4A there is you're going to see the hepatocellular pattern. That is enzymatic signature. So if the ALT, AST is greater than the ALK phos, then you know you're in hepatocyte territory, and that's the primary site of injury. And the causes there are the viral hepatitis, autoimmune, drug-induced. So then you'd go on and order the serologic markers to clearly diagnose that. If you're in step 4B, you have a cholestatic pattern. That's ALK phos and GGT is greater than ALT, AST. That's where you're going to think about obstruction and bile stasis, and the liver is intact, but the bile can't drain properly. And the next step is going to be imaging and ultrasound, and that's the first line that distinguishes intrahepatic versus extrahepatic obstruction. And then you might decide plus or minus MRCP. Okay. So the big take-home message here is dark urine plus pale stool. That's a conjugated bilirubin problem. It's water-soluble and renally excreted. If it's pruritus, that's a cholestasis problem due to bile salt deposition. And if it's hemolysis, never causes dark urine because unconjugated bilirubin is albumin-bound and not filtered. So jaundice is not a diagnosis. It is just a symptom of disrupted bilirubin flow. And the key is going to be to figure out where that problem is happening. All right, so now we've looked at liver disease piece by piece and enzymes. So now we have this three-part framework to look at here. And the labs are going to tell you the biochemical signature and ask the question, what is the pattern of injury? Is it hepatocellular versus cholestatic versus mixed? And then imaging is going to tell you the anatomic structures, and the symptom will tell you the clinical correlation. So there you have cholestatic labs plus right upper quadrant pain. That's going to lead to an ultrasound with MRCP. And then you can use various risk scoring criteria to help you stratify the disease process to determine severity. Once you've identified the likely cause, the next question is always going to be, how sick is this patient? And the MELD score is that model of end-stage liver disease, and that's used in cirrhosis. And the purpose of that is to estimate that 90-day mortality to help guide transplant prioritization. And that can get reassessed as the condition changes, and you can quickly move up and down on the list. What would be complete without talking about children? We have to talk about the pediatric people here. We have biliary atresia. This is a neonatal emergency. This is progressive obliteration of the extrahepatic biliary tree, which can lead to cholestasis and secondary cirrhosis if untreated. This presents with jaundice persisting beyond the 2 to 3 week period of neonates, and with conjugated hyperbilirubinemia. They have pale stools and dark urine. And what's happening here is you have a physiologic jaundice in newborn that's unconjugated. That's biliary atresia is conjugated. So it's normal to have physiologic jaundice in a newborn, and that represents the unconjugated. But biliary atresia, this is the bigger problem. This represents a conjugated problem, and that's the key distinction. This is a surgical diagnosis, and they have to operate within 8 weeks to prevent liver failure. If the infant is jaundiced after 2 weeks, that's when you check direct bilirubin. It's a small test and it can save this kid's life. Another GI problem in children is Hirschsprung's disease. This is a neonatal obstruction pattern. This is an absence of ganglion cells in the distal colon. And what happens is you have a failure to pass meconium within 48 hours. That's the red flag for this. You will see abdominal distension, vomiting, and chronic constipation. And you may also see explosive stool on a rectal exam. That's the tell. The diagnosis is confirmed with rectal suction biopsy showing an absence of ganglionic cells. The tie-in with this, though, is that this is not a hepatic disorder. This appears here because obstructive symptoms in the neonate will often overlap with cholestatic presentations. So while this differentiates mechanical versus metabolic and motility-based obstructions. And finally, there's also pediatric inflammatory bowel disease. This shows itself as growth failure, delayed puberty, and malnutrition, and it often will precede GI symptoms. Disease is typically more extensive in pediatric ulcerative colitis and more aggressive in Crohn's disease. There are extra intestinal manifestations of this, such as arthritis, erythema noduosum, and that can appear before these intestinal findings. So if you see this in children, that should set the stage to go investigating for this inflammatory bowel disease. In a child with any sort of growth deceleration, mild anemia, you have to consider inflammatory bowel disease, even in the absence of overt diarrhea and pain. There's also, this is where Wilson's disease gets diagnosed. This is a copper accumulation from an ATP7B defect, genetic disorder, and it's diagnosed by low ceruloplasmin. Also, Kaiser-Fleischer rings in the eyes, and they can also have neurological signs of irritability. That alpha-1 antitrypsin makes another appearance here in inflammatory bowel disease. This is a misfolded protein which can accumulate in the hepatocytes, and this can manifest as neonatal hepatitis. And like we said last week, emphysema before the age of 40. If you have emphysema before the age of 40, you might have an alpha-1 antitrypsin deficiency, and this is the GI manifestation of that. You can also have glycogen lipid storage disorders. This is an abnormal energy storage of hepatocytes. And the diagnostic clue here is hypoglycemia, hepatomegaly, and elevated liver enzymes. So if you notice that, that could be the disorder. And also, finally, these mitochondrial hepatopathies. This is impaired oxidative phosphorylation. The clue here is a multi-system disease with a lactic acidosis and elevated AST, ALT. So in pediatrics, the metabolic disease often presents as hepatomegaly and failure to thrive rather than jaundice alone. And developmental age-specific considerations have to be considered. Remember, these kids are not small adults. Drug metabolism is altered with age as well. Nutritional demands are higher in children, so they will have first derailments in their growth curves. Chronic illness in childhood will affect also cognitive and psychosocial development, so that has to be integrated into the care planning. And the problem in pediatrics is if you miss this, every diagnosis carries a developmental footprint. So you're not just preserving the organ, you are preserving that trajectory of life because it affects all the multiple systems that can be affected. Okay, so just as this pediatric hepatology reflects this developmental vulnerability, we need to look at the geriatric side of the situation now. So in geriatrics, their big culprits here are things like polypharmacy, and polypharmacy can become this hidden hepatotoxin. They're often typically on more than five medications at a time, and each one is competing for the same CYP450 pathway. So NSAIDs and anticoagulants will compound risk of liver insult. NSAIDs can cause things like erosive gastritis, peptic ulcer disease, and renal hepatic cross toxicity. For also, anticoagulants increase the bleeding risk. So imagine now when you combine these two together, which is not uncommon in the elderly. So when an older patient presents with melena, bruising, anemia, you have to think about medication synergy until proven otherwise. And you also have to look at gas. The greatest hepatic threat in geriatrics is not infection or alcohol. It's people with too many prescriptions and no one is willing to deprescribe. Another big thing to look at here is reduced hepatic reserve and drug metabolism. With aging comes reduced hepatic blood flow, which leads to hepatocyte mass and microsomal enzyme activity. So they clear drugs slower, which means there's more risk for toxicity to happen. The elderly liver doesn't fail, it just gets really tired, and then eventually it poops out. So, some atypical presentations. Pain perception is blunted with age, so they can mask abdominal catastrophes for a long time. So, a perforated ulcer may present as mild discomfort in an older person. Hepatic encephalopathy may manifest as delirium rather than the classic asterisk and wrist flapping. So, you always have to interpret confusion in the elderly as a systemic signal rather than just psychiatric in nature. Um, so there are some age-related conditions like gallstones and ischemic colitis. This increases with vascular disease as well. And there's lower thresholds for endoscopic evaluation in the elderly. So, other major factors, obviously, everything is decreased, including motility and gastric emptying and colonic transit times. So, in the elderly, GI distress will often mean mechanical inertia rather than acute inflammation. Also, the biome shifts in the elderly. So, there is a probacteria short chain fatty acid condition where they are more prone to developing inflammatory bowel conditions. There's a heightened disposition to C. diff. And there's also altered mucosal integrity. So there's a leaky barrier that can happen. So slow bleeds and perforations are not uncommon. And so you have to be mindful of that. As well as altered drug metabolism with all these drugs competing for the same CYP450 pathway. The other thing is this is the high risk for cancers to develop. So cancer screenings are a must here. And you have to adjust your clinical index of suspicion based on age. So the big thing to take away here is you always want to look for patterns, look for hepatocellular, cholestatic, and ulcerative colitis patterns. Don't memorize the disease processes. Pay attention to the ratios of ALT to AST, ALK-Phos to GGT. Pay attention to peptic ulcer disease. Know that we're talking about overproduction versus protection as the key factor there. Portal hypertension, know the patho of that because it's this multi-system, increased resistance, increased flow, leading to hyperperfusion states triggering the hepatorenal syndrome, and know the red flags to escalate, bleeding, nocturnal symptoms, and weight loss, anything greater than age 50, and escalate the diagnostics. These are the case presentations here. So quickly, this is a 45-year-old male office worker with a 3-week history of burning epigastric pain, taking ibuprofen, and the pain pattern is worse on an empty stomach. So that is describing to you the classic duodenal ulcer signature. And there are the labs, microcytic iron deficiency anemia. So benign abdominal exam does not rule out bleeding. It could be slow and chronic, and it can occur without melena. And those are the differentials to consider. This 28-year-old graduate student, the symptoms, 8 weeks of bloody diarrhea, 4 to 6 stools a day, tenesmus, weight loss, 10 pounds, low-grade fever, H&H is 11, CRP is elevated, negative stool culture. What are we describing here? This is a chronic inflammatory state. So we're trying to distinguish between ulcerative colitis and Crohn's disease. So what features this, what tells you the distinction? Well, the tenesmus, bloody diarrhea, and continuous symptoms, that is the calling card of ulcerative colitis. Here we have a 60-year-old with ascites and confusion. This is a decompensated cirrhosis case, classic, and it's not benign. So every finding here tells you that the liver has moved beyond injury to systemic failure. And in the 30-year-old, sorry, the 3-year-old case here, moderate. We look at the same case. Moderate sustained alcohol use. Where's my 30-year-old case here? So you have this 3-year-old who presents with a 6-month history of chronic loose stools for 3 to 5 days, abdominal distension and weight loss, and the height and weight is below the 5th percentile. So what are we looking at here? This deranged growth pattern. You need to think about this inflammatory bowel disease as a presentation, or at least refer for the investigation in the workup. We can't just say that's a benign finding. All right, guys, that is all. I've kept you slightly over your time.